Welcome to my talk on hematuria and renal cell carcinoma RCC. This is a very important topic which you must be familiar with, assessing a patient with hematuria and also managing it when you think of it as a renal cell carcinoma. Okay, what is part 1? We will deal with hematuria. So what is hematuria? Hematuria is the presence of blood in the urine. It can be microscopic or macroscopic. Microscopic, when it is not visible, is called non-visible hematuria, NVH. The urine looks grossly normal, but blood is detected either by dipstick or urine analysis. So this is microscopic. Macroscopic, on the other hand, is called visible hematuria, VH, where urine on inspection, okay, it is red, brown, or brownish tinge, or the presence of blood clots itself. So it's frank hematuria. Microscopic examination of the urine is very essential for both these types of hematuria. Some drugs or food can discolor the urine, simulating macroscopic hematuria. This is called pseudohematuria or false hematuria. Now, what's the importance of this types of hematuria that we are talking about to distinguish? Is visible hematuria, there's a 14% chance of malignancy being the cause, especially renal cell carcinoma. Whereas in non-visible hematuria, the incidence of malignancy is very much lower, only 3%. And the other important factor is the age. Younger patients, less than 43 years old, the younger you are, the least the risk of malignancy. Another type of classification is called glomerular and extraglomerular, besides the visible and non-visible hematuria. Now, this glomerular and extraglomerular we will discuss in the next slides. Okay, so we go through classifications again. You've got visible hematuria, okay, where the blood is visible in the urine. Non-visible hematuria, or NVH, formerly called microscopic hematuria, where the blood is not grossly visible. And the second type, non-visible hematuria, there are two types. Symptomatic non-visible hematuria, where patient has got symptoms of suprapubic pain or renal colic suggestive of the cause, but the urine has to be confirmed for the presence of blood. The second one is asymptomatic non-visible hematuria. Patients have got no symptoms, but hematuria is confirmed on microscopy, but no associated symptoms. Then the other one is the pseudohematuria or false hematuria, where the blood is red or brown in color, suggestive of hematuria, but it's not secondary to the presence of HB, which can be checked on urine analysis. Now, what are the causes of pseudohematuria? Pseudohematuria, there are a number of causes, of which the important things will be medication. Rifampicin and metaldopa are common drugs that can cause hematuria. Hyperbilirubinemia in obstructive jaundice, where there's conjugated urinamine in the urine, which gives it a dark color. Myoglobinuria from the muscles, where there's muscular disease, muscular problems, or the patient has got severe muscle injury. And then food, beetroot and runab. Beetroot here and rhubarb and beetroot are important sources of this pseudohematuria. Then, as I was telling you, this glomerular or extraglomerular is very also important. It gives you an idea as to the possible cause of this problem. Okay, now how do you differentiate? By urinary findings. Red cell cast may be present in glomerular hematuria, but absent in extraglomerular. Red cell morphology is dysmorphic. That means the red blood morphology is very different, and it's not uniform. It's varied. In this case, is in the case of glomerular hematuria, but the cells are very uniform in shape in extraglomerular hematuria. Proteinuria may be present in glomerular states, whereas in extraglomerular hematuria is usually absent. Presence of clots is absent in glomerular hematuria, may be present in extraglomerular hematuria. The color of the urine may be red or brown in glomerular type of hematuria, but in extra is usually red in color. Okay, the important thing is in glomerular hematuria, the findings are usually due to medical causes. Okay, the causes are usually medical, whereas in surgical conditions, it is usually mainly extraglomerular hematuria. So this is a very useful classification of to decide whether its cause is medical or surgical. Okay, now we come to the symptoms, details of symptoms of hematuria. Okay, as I said, we are talking about visible hematuria, gross or macroscopic. First, pain or painless, very important. Either the hematuria is associated with pain or painless. It will help you to localize the site of the lesion that you may be having. Secondly, whether it's intermittent or continuous. Then the timing to maturation is very important, and this timing can be classified as initial stream, total stream, and terminal stream. Okay, now in initial stream, the first 10 to 15 mils of blood stain. After that, the urine becomes clear. Whereas in terminal stream, terminal hematuria, which is usually from the bladder or the neck or the bladder, the final 10 to 30 mils is blood stain. The initial stream of urine is normal. If it is throughout or total hematuria, it is usually from the upper urinary tract, especially kidney, ureter, and also the bladder, body of the bladder. Okay, these are the important signs or symptoms that you have to elicit from the patient when he or she has hematuria. The other important thing is generalized bleeding from coagulopathy. Okay, patient taking drugs, or maybe patient has got some form of illness which suppresses the coagulation problems. So in these cases, the bleeding, if it is generalized, then easy to diagnose. But if it is localized to the urinary tract, sometimes we may have to do the proper investigations. Okay, these are the common causes. There are four main causes of hematuria: trauma, infection, stone, and neoplasm. So these are usually the surgical causes of hematuria. Okay, here you got there. It can be from the upper urinary tract or lower urinary tract. Upper urinary tract is usually the kidneys and the upper ureters. Okay, and the various causes are all shown in red. This one, in a red box, it is medical problem. If it is in green, then it is surgical. Okay, so you can see upper urinary tract, usually hypernephroma, renal tumors, transitional cell tumors, carcinoma of the kidney, Bill's tumors. Okay, whereas in the medical conditions will be blood dyscrasias, sickle cell, anticoagulation, okay, TB, infection of the kidney, and in the ureters, it is usually focal and glomerular nephritis. Okay, in the kidney here. So these are the medical causes. Prostate, very important. Usually is benign, prostatitis, or can be malignancy or BPH. Okay, and the bladder, again, these are the causes of the lower urinary tract symptoms. Okay, so surgical conditions are all encased in a green box here, whereas the medical causes in the red box. Okay, now we come to again continue with the sources of causes of hematuria. It can be from the kidney, can be from the ureter, from the bladder, from the prostate, or the rest of the urethra. Okay, can be glomerular medical causes, can be glomerular nephritis, Alport's disease, IgA nephropathy, and these are all cases due to medical problems. Again, in the box, red box. Whereas the extraglomerulars, Usually it will be neoplasm, pyelonephritis, stones and trauma. Okay, these are all encased in the green boxes, and the various conditions that affect from the kidney, ureter and bladder, they are all given in these boxes here that you can go through. Okay, next we come to the investigations of hematuria. First, the most simple investigation is detecting the blood in the urine. Nowadays can use dipstick or urine analysis. The traditional method is the urine analysis, which we are all comfortable with, but nowadays simpler methods using a dipstick can be done in the clinic or in the house itself. Okay, but microscopy remains the cornerstone of the diagnosis of hematuria. It looks for the RBCs in the blood, in the urine. Next, imaging methods, among which the commonest, simplest, most is the KUB, especially if it's a painful hematuria. You may want to rule out trauma, or you want to rule out stones. KUB is still a useful examination. Next simple one is your ultrasound KUB. This is very important. We should be able to describe the status of the kidneys, whether there's a mass, whether there's a stone, if there's a mass lesion, whether it's a solid or a cystic lesion. And the gold standard method of investigation is your CT urogram, CTU, using contrast enhanced CT scan. Okay, this is the most important and most useful in terms of diagnosis and determining whether it's malignant or otherwise. And the final one is your flexible or rigid cystoscopy, cystoscopic examination, CE. So this is when you decided it's a lesion in the bladder, in the urethra or lower ureters, then this may be very useful diagnostic investigation. Okay, now what's general outline of the management of the patient with hematuria? First, you confirm the hematuria by urine analysis. If there are more than 3 RBCs per high-power field, then very high chance it is due to hematuria. Acute, the onset is that it's acute, and whether it's unilateral or whether associated with pain. This will give you whether it is nephrolithiasis or urethral lithiasis. Okay, ureteric stone. Symptoms of UTI, urine, where there's increased WBC and urine nitrites, then you think of UTI, and the treatment is urine culture and sensitivity to determine the organism and antibiotics. Evidence of glomerular bleeding, such as proteinuria, RBC scars or dysmorphic RBCs, he has to be referred to a nephrologist for further investigation for whether he or she needs the renal biopsy. And risk factors for malignancy, if these are present, which we will go through in the next second part of the lecture, then you refer the patient to a urologist and see whether there is need for cystoscopy. And these patients, when they suspect malignancy, CT urography, okay, is very, very important. You do a CT urography and then you refer the patient to the urologist. There will be a small number of cases, portion of cases, that cause is unknown, unable to detect with all these investigations. These patients, you refer them to nephrology and see whether they need other forms like biopsy. Okay, this is a simple outline of the management of hematuria. There are 3 groups of patients with hematuria. The third group, I think we must exclude them first initially, and this, whether it's the drug history, food history, all these are very important. So false hematuria. These first 1 and 2 are very important, and these are genuine hematuria, non-visible or visible hematuria. And these patients are subjected to the various investigations which I mentioned: urine analysis, urine culture and sensitivity, blood tests, X-rays, ultrasound, CTU, and biopsy if necessary. With subjecting the patient to these investigations, you may be able to discover a tumor, the diagnosis, stone, infection, urinary tract infection, or trauma. And the treatment is according to the cause. Okay, if it's tumor, subject to surgery, endoscopy. Stone, you go for lithotripsy. Infection, you start with antibiotics. And trauma, normally you use conservative. Later you go for, if the bleeding persists, then you go for surgery. Okay, now we come to part 2 of the lecture, which is on renal cell carcinoma, RCC, which is also an important cause of hematuria, gross hematuria. Before we proceed on with the hematuria proper, renal cell carcinoma proper, we shall briefly look at the anatomy, which is important in the management of the patient. Okay, under the anatomy, you have these two pictures here. On the left side, you have given you the outline of the urinary system, which consists of a pair of kidneys in the upper abdomen, which are connected to the bladder in the pelvis by the ureters. The kidneys are located between T12 and L3. Okay, right side is slightly lower because of the presence of the liver here, and the left side is slightly higher. Okay, now the kidneys are supplied by the renal vein, which comes from the aorta, abdominal aorta, and the veins of the kidney drains into the renal vein into the IVC. Okay, aorta and IVC are the main sources of blood and drainage of blood. Okay, now next we come to the picture on the right side here. It shows you the detailed anatomy of the kidney, which is horseshoe shape. Okay, and then the upper pole is very closely adherent to the adrenal gland, which is adherent to the upper pole of the kidney. And the kidney itself, it consists of a cortex, medulla, and pelvis. The cortex is the filtration systems are located here, the glomerular complex. The medulla is mainly the drainage. The tubules are here, which drain the urine that is filtered into the receptacle of the pelvis here. From here, the urine is diverted into the ureter, which drains it into the bladder in the pelvis. Okay, now the kidney itself is covered by 3 layers. The first layer, the inner layer, is known as the capsule, thick fibrous capsule here, which is tough. Okay, this is a renal capsule. Inner to that is a lining of fat known as the perinephric fat. Okay, perinephric or perirenal fat, perirenal fat. Okay, the yellow in color here. All right, here also it goes down. And the third one is your fascia. Okay, and this is your Gerota's fascia, which covers the whole of the kidney as well as the adrenals. It plasters the adrenal into the upper pole of the kidney. Now, the function of these 3 layers, especially the perinephric fat, is to act as a cushion to protect the kidney from minor forms of trauma. Okay, that's very, very important. Okay, and the renal artery and the renal vein there at the pelvis here, renal pelvis, so the hilum of the kidney, they go into and exit from the renal pelvis. So in summary, the kidneys lie retroperitoneally in the abdomen and either side of the vertebral column. They typically extend from T12 to L3 vertebra, although the right kidney is often situated slightly lower due to the presence of the liver. The kidney is covered by 3 layers and it consists of 3 layers structurally: cortex, medulla, and pelvis. Okay, now we come to the renal cell carcinoma proper, the proper lecture. Okay, also known as the renal adenocarcinoma, arises from the epithelium of the proximal convoluted tubule. So it's an extraglomerular type of hemorrhage, hematuria. It's usually because of its location It is frequently detected coincidentally when going for some other form of major investigation. Three major types: clear cell, papillary cell, or the chromophobe cell are RCC. And so the three main types, of which the most common is your clear cell carcinoma. Male to female is about 2:1. More men than female are affected. The peak incidence is between 65 to 75 years of age, and it is uncommon before the age of 40. If present in patients less than 40 years of old, it is in age younger patients, it's high possibility of underlying hereditary kidney cancer syndrome, which occurs in about 3 to 5% of all cases. Okay, so younger patients, if it occurs, you have to think of a familial origin, and you may have to screen the family as well. Clear cell carcinoma is the most common type of cancer, accounting for 83 to 88% of the tumor. Now, the risk factors, as I said, is common in the elderly, 60 to 70 age group, male to female, male higher. Obesity is an important factor, hypertension, okay, and cigarette smoking. So these are common conditions that you must look for in the patients. And other conditions will be medical conditions, kidneys, like chronic kidney disease, hemodialysis, kidney transplantation, and acquired polycystic kidney of the kidney. Yeah? Then the important one is your family history of renal cell carcinoma, especially patients with underlying von Hippel-Lindau disease, in which there are multiple cysts and tumors in various organs. Exposure to cadmium and asbestos, and the other important thing which occurs is your non-steroidal anti-inflammatory drugs abuse. Okay, overuse of these drugs may lead to renal cell carcinoma. Okay, now there's something about this update in genetics, the von Hippel-Lindau gene, or the VHL gene. Okay, genetic syndromes occur in about 4% of renal cell carcinoma. The main 4% are hereditary. They occur in families, and this is related to this VHL gene. The most common is the important gene is the von Hippel-Lindau gene, VHL syndrome, we call it, where patients inherit a mutated VHL tumor suppressor gene. Okay, so this predisposes them to clear cell renal cell carcinoma and other tumors. So VHL tumor suppressor gene. Okay, so how it works we see in the next slide. Okay, the pathophysiology of the VHL gene is the key. So this brings us to the critical concept in RCC pathophysiology. The VHL gene is a classic tumor suppressor gene. It classically suppresses tumor. Its normal job is to tag a subscription factor called HIF, hypoxia-inducible factor, for degradation. When the VHL gene is mutated or inactivated, either due to inheritance or sporadically, the HIF factor, okay, hypoxia-inducible factor, accumulates. This tricks the cell into thinking there is severe hypoxia, even when there's not. And this HIF turns on, as a result of this detection of false hypoxia, it turns on a pro-growth, pro-angiogenesis program, leading to the overexpression of genes like the VEGF, vascular endothelial growth factor, and the platelet-derived growth factor. Okay, these two factors become stimulated and they become overexpressed, and as a result, there's proliferation of blood vessels and renal cells. And this uncontrolled growth of blood vessels formation is what drives the development of the most common type of subtype of renal cancer, which is the clear cell carcinoma, RCC. Okay, this is a simple pathophysiology to understand the genetic basis of RCC. Okay, this chart summarizes what I was telling you. This is the VHL gene become either inactivated or mutated. As a result, it cannot detect HIF. Okay, so HIF accumulates, cannot be inactivated, and this leads to the formation of the VEGF, PDGF, and TGF. And these lead to overgrowth of vascular endothelium and also the platelets and endothelial growth. So this leads to tumor. Okay, and these are drugs that can be used to suppress these features. As a result, it is known as a target therapy, which we will talk about it later. Okay, next we come to the clinical features. Clinical features of renal cell carcinoma. Okay, large majority of them is asymptomatic. Renal tumors are often identified incidentally during imaging investigations for other purposes. Asymptomatic patients, about 60% of cases present with hematuria, 40% loin pain and only, 25% with mass. Okay, now about 15% have of the triad of pain, hematuria, and mass. So you got three types of pain, hematuria, and a mass. So these three occurs only 50%. Okay, so hematuria occurs in 60%, loin pain 40%, and loin mass is 25%. And this, but the whole, all three together is only 15% of them have this. Unexplained weight loss, anemia, fever, PUO, raised ESR, polycythemia, disorders of coagulation, abnormalities of plasma proteins and liver function tests, paraneoplastic syndromes, and left varicocele. So these are other symptoms which the patient can have. Okay. Now, this is a diagram to show you the occlusion of the left testicular vein here, which results in varicocele in patients, older patients. So here you have the same anatomy here. You have your testicular veins here, which empty into the on the right side into the vena cava. So there's a smooth flow. Okay, whereas in the left side, it enters into the renal vein at a 90 degrees. As a result, there is some slowing down of blood flow here, and that leads to varicocele. So this is the reason why when a patient, older patient with left-sided varicocele comes in, you must always think of some form of obstruction here, which is in many cases can be due to invasion of the cells invading into the renal vein, and that causes obstruction and varicocele. Now, the other important thing that you must know about kidney tumor, renal cell carcinoma, is paraneoplastic syndrome. Now, these are symptoms due to symptoms which are not related to the tumor itself, which is due to some other form mechanism. So this is due to endocrine function, which can be affected by the RCC. It's ectopic hormone production, erythropoietin, renin, insulin. Erythropoietin causes polycythemia, increased RBC. Renin causes hypertension. Insulin causes hypoglycemia. Adenocorticotropic hormone, ACTH, causes Cushing syndrome, and parathyroid hormone causes hypercalcemia. Among all these paraneoplastic syndrome symptoms, the three most common one will be polycythemia, hypertension, hypercalcemia, and sometimes hypoglycemia as well. Other things can be hematological, where there's bone marrow involvement, the anemia, and metabolic, can be pyrexia of unknown origin. Investigations for RCC, full blood count, anemia, you will look for anemia. Urine examination, okay, apart from RBC, you look for malignant cells. Cytology for malignant cells. Abdominal and kidney ultrasound scan, very important. Look for hydronephrosis, mass lesions and stones. CT scan is, as I told you, most effective, and is you look for the mass lesion in the kidney, other organs, lymph nodes, and staging. Okay, this is your CCET, CT. Okay, very important, most effective. Okay, and the bone scan, PET scan, and chest X-rays for staging. So CT scan together with bone scan, because bone is a important place for the dissemination. PET scan and chest X-rays are very important. Diagnosis, classical triad, clinical, hematuria, loin mass, and loin pain. If these three are present, then most probably you have to look for RCC. And these are usually incidental findings. Sometimes you have just one of them present, either hematuria, mass, or pain. Next, ultrasound, initial investigation, allows you to differentiate between tumor and simple renal cyst. Staging, CT scan with contrast enhancement of the chest, abdomen, and pelvis. CT guided biopsy or ultrasound guided biopsy for tumors less than 3 cm in diameter with no evidence of metastatic spread, and when the nature of the lesion is uncertain. Okay, so the biopsy is not done for all cases. When the tumors are small, no evidence of metastasis, and when the nature of the lesion itself is uncertain. Ultrasound or CT scan guided biopsy may be used to avoid unnecessary nephrectomy for a benign disease. Nowadays, what's becoming important is PET scan, positron emission tomogram, reveals the metabolic or biochemical function of your tissues and organs. Okay, these are the simplified I have simplified the various diagnoses and staging. Okay, this is an ultrasound scan of a patient. Okay, there's a mass here. This is the kidney, large mass in the kidney, which is heterogeneous and hyperechogenic. Okay, and it's surrounded by a capsule. In this case, the capsule is well encapsulated, but there's a suspicious area where probably it has breached the capsule. So it becomes T3. And here is an ultrasound guided biopsy. How a biopsy is done. This is an ultrasound probe placed here to localize the kidney and the mass in the kidney. And then you use a needle to enter into the kidney mass that is distant, and then you take a biopsy. So this is the ultrasound guided biopsy. Sometimes it can be used CT scan guided as well. Okay, this is another CT scan of the left kidney here, showing you a mass in the lower pole. Okay, it seems to be well encapsulated, especially but except in this where the psoas muscle is here, where the arrow is here, there maybe is already stuck to the psoas muscle. Here another one with the upper pole here, there's a mass in the upper pole, very well encapsulated except for this part probably in this instance. So these are two CT scans to show you in different patients how renal cell carcinoma will appear on CT scan. Okay, here lower pole here, okay, a definite growth here, but this is very well encapsulated. Here also very well encapsulated. Then you have got this hypodense type of tumor here. Okay, so these are things that you will look for will be the lesion itself, the size, the borders, especially the capsule, and whether there are lymph nodes. Okay, these are the 4 or 5 things that you will look for in a CT scan, which can be able to give you information as to whether it is benign or malignant. Okay, the staging of the renal cell carcinoma, stage 1 to 4 according to the TNM classification. Okay, you have got your early T1 and T2, okay, which is here. T1 is the less than 7 cm, T2 more than 7 cm, and this is within the within the kidney, within the capsule of the kidney. Then you got your T3 ingrowth perinephric tissue, but not beyond the Gerota's fascia. And tumor thrombus is in the vein. The renal vein has got a tumor thrombus. Okay, that means 3. Okay, 3 is when it's perinephric tissue, but it has gone outside the kidney, but not beyond the fascia, and the vein, renal vein, is involved. Stage 4 involves the ipsilateral adrenal glands and invades beyond the Gerota's fascia. Okay, and this one is the diagram to show you the various stages. Okay, this is the kidney here. This is the renal vein. So stage 1 is here, less than 7 centimeters within the kidney, within the renal parenchyma. Stage 2, when it is become bigger, more than 7 centimeters, but still within the renal parenchyma, it does not breach the capsule. Stage 3 is the yellow one here. It is breached the capsule. It has come out of the capsule, but not outside the Gerota's fascia. Or it has also already have got a thrombus in the renal vein here. Okay, one is breaching the capsule and the other one is thrombus. These two will suggest it is stage 3. And stage 4, the blue one here, where it has gone through the capsule, the Gerota's fascia, and to the abdominal wall. It's stuck there. Okay, so these are the various stages. The other things that you can look for is your lymph nodes here. Okay, hilar lymph nodes. Okay, renal hilum here, lymph nodes around here, the para-aortic lymph nodes here, and para-pancreatic hilum. Okay, these are the important lymph nodes that you have to look for in CT scan. So the lymph nodes will be para-aortic, renal hilar lymph nodes, and caval lymph nodes. These are the 3 types of lymph nodes that you want to look for. Now, the treatment for renal cell carcinoma. Surgery is the main line for simple. Okay, surgery is in the form of nephrectomy. It can be a partial nephrectomy, which is also known as the nephron sparing nephrectomy, where part of the kidney is removed. Just only a part. Total nephrectomy, the entire kidney is removed. And radical nephrectomy, depending on how far the disease has spread, and extensively, as well the more extensive removal of the kidney. We have to remove the surrounding lymph nodes and the renal gland and the Gerota's fascia. Next, radiation therapy can be given externally by a machine or internally using brachytherapy using needles or wires. Okay. Thirdly, chemotherapy for the use of IV antibiotic, IV mitotic drugs, anti-mitotic drugs. But sad to say, generally the renal cell, the carcinoma, the cells are quite not so effective, not so more resistant to this all the chemo drugs that we have, are not very responsive. So newer methods have come in, and these are new methods will be these 2 which I mentioned here. Biology therapy, immunotherapy. Okay, works nowadays. It seems to work well with these renal cancer cells. And very important now has come is target therapy. Okay, newer kind of cancer therapy is becoming more popular nowadays. Drugs are used to attack certain cancer cells which without damaging the healthy cells. And these cancer cells have got some form of signals on them, so the drugs can go and just attack the right target. And one of the most important group of drugs will be the tyrosine inhibitors. Tyrosine kinase inhibitors, TKI, they call it TKI, tyrosine kinase inhibitors, which will damage or kill the cancer cells without harming the damaged cells. So this has become, targeted therapy has become the first line treatment for after surgery. Now they're also trying out on vaccines and cytokines and hormone therapy, and this also may be becoming more useful in the future. Okay, surgery, as I told you, radical nephrectomy, whole kidney. Okay, whole kidney is removed. including the perinephric fat, renal fascia, okay, the Geroda fascia, the upper part of the ureter, the renal gland, and also the lymph nodes. So this is radical nephrectomy. Okay, and then you see renal artery and vein are ligated flush with the renal IVC and aorta. Okay, this is a tumor here, RCC here, where the removal of the kidney, radical nephrectomy, you remove the kidney with the capsule and the fascia and the fat. Perinephric and fascia also have to remove. That renal gland also you have to remove. If it is in the upper pole, you have to remove that gland. And regional lymph nodes are also removed. This is radical nephrectomy. Okay, difference between radical and partial. Partial nephron sparing, where you just excise the tumor and then you suture it back. Okay, so you can see the difference, very wide difference here. Okay, partial nephrectomy, completely remove the primary tumor with the preserving the largest possible amount of healthy renal parenchyma. Okay, so it is very useful for patients with small tumors, localized tumors, T1, T2. So you got enough kidney to leave behind for it to function. It's indicated in patients with tumor 1 and normal contralateral kidney. So the other important thing is the other side is very important before you do a nephrectomy. If the contralateral kidney patient has got chronic renal problem, contralateral kidney also not so good, then you want to try to do partial nephrectomy. And it's also strongly recommended in patients with RCC who have only one kidney, anatomically and functionally. That means other kidney has been removed or not functioning, then you got no choice but to keep the kidney and do a partial nephrectomy. Then those with bilateral synchronous RCC, okay, that means both kidneys also have got tumor, so you can only do partial in both sides. And those patients with von Hippel-Lindau syndrome, okay, this means before it becomes malignant, practically you want to remove the tumor, so you do a partial nephrectomy to prevent the further in future from developing RCC. Okay, partial versus radical nephrectomy. Whenever possible, partial nephrectomy should be preferred treatment. Comparable long-term cancer control, lesser risk of chronic renal insufficiency and proteinuria. So if possible, you want to keep the kidney as far as possible. So you do a partial nephrectomy. The other important thing which is may be done is radio frequency ablation and cryotherapy, and these also more minor procedures, and these are usually reserved for alternative strategy for very elderly patients, competing health risk, okay, and limited life expectancy. He's already got some other problem, renal failure, heart failure, other cancer, so they are not suitable for surgery. So you want to do something local ablation so that they can just prolong their life. Can be considered for growth more than 3 to 4 centimeters. Completely destroy all viable tissues, and the procedure you can destroy all the viable tissue. Can be done either laparoscopically or percutaneous approach under CT scan or ultrasound guidance. But the problem is it has got high recurrence. So we are not so worried about this because the patient's life expectancy is limited because of his own other problems. So generally summarize the treatment. Okay, for stage 1 and 2, radical nephrectomy, partial nephrectomy, nephron sparing nephrectomy. Okay, and then you may use minimally methods of thermal ablation. If it is a very small tumor, about 2 centimeters, if you think your percutaneous methods can help, then maybe it is useful. Okay, then for adjuvant or palliative treatment for T3 and 4, these are the things that you cover. Okay, immunotherapy, and target therapy becoming very important. Target therapy is now becoming the most important. Tyrosine kinase inhibitors, TKI inhibitors, and followed by immunotherapy. Okay, also becomes very important. These are some of the names which you may not remember, but you must know the groups and division. Chemotherapy, as I said, renal cell carcinoma, not very. People are going away from it because it's not so effective. Radiotherapy for localized tumors, yes, you may think of radiotherapy, especially in old people. You may want to do using percutaneous, called brachytherapy. Okay. Now, vaccines and cytokines, hormones, these are becoming important. These are some of the drugs that are TKI, tyrosine kinase inhibitors. All these starting with the word tinib, getfinib, erlotinib, all these teams are known as the targeted therapy. Okay, summary of treatment patients again. Stage 1, 2, 3, and 4, which I showed you just now. Stage 1, okay, give you tumor less than centimeters. Stage 2, more than 7 centimeters. These 2, 1 and 2 are good prognosis, so you go for surgery. Management, partial nephrectomy. Whereas in patient in 3, okay, 3, okay, here, okay, this will you go for patient 3 here, tumor for the major veins. So major vein, that means the tumor has gone in the renal vein and it's also gone out of the capsule. Okay, so in this case, you want to do a radical nephrectomy plus a renalectomy, okay, and tumor thrombus excision. So it's a very major procedure. If the patient is fit, you subject them to this. And stage 4, tumor beyond the Gerota's fascia, maybe distant metastasis. Of course, important thing, the survival rate also is very much less. So you may want to do cytoreductive nephrectomy. Cytoreductive, that means is you give all sorts of medical treatment, cytotoxic drugs, reduce the downstage the tumor, and then go for nephrectomy. Okay, prognosis, very important. Stage 1, okay, stage 1, this one, 95% 5-year survival rate. Stage 2, tumor more than 7 cm, 88%. Stage 3, 59%. And stage 4 is 20%. So it's between best prognosis of 95% in stage 1 to a worst prognosis of 20%. Okay, here, the summary here, stage 1, 95%, stage 4, 20%. So it's very important for you to detect a tumor at this stage. This in renal cell carcinoma is not that easy to detect it that early because most of them do not have any specific syndrome. If they do not have hematuria, then the diagnosis becomes delayed. If they come with, if you're lucky, they get hematuria, then diagnosis may be early. All right, that's very, very important. Okay, important points to take home from this lecture: renal cell carcinoma, loin pain, mass, hematuria. This is a triple triad. If you have it, then it can be easily diagnosed. Unfortunately, only 15% of the patients will have these three things together. Hematuria is usually painless and visible hematuria. Okay, varicocele in older patients, if they have a left-sided varicocele, always you must think of renal cell carcinoma. Then vague aching pain, loin, and loss of weight. Paraneoplastic syndromes, polycythemia, hypercalcemia, and hypertension. Okay, I put a star here to remind you that most of the patients on diagnosis may be asymptomatic. Many of them are quite fit and quite well looking. You will not suspect them to be malignant. So this is the thing that delays our diagnosis. That's a very important take-home point. Okay, thank you for joining me for this lesson, for lecture. See you again another day. Thank you.